Good morning, everyone. So today's topic is pulmonary surgery. So let's start with introduction. Lung surgery is the surgery to repair or remove lung tissues, biopsy of an unknown growth, lobectomy, lung transplant, pneumonectomy, surgery to prevent the build-up or return of fluid to the chest. Surgery to remove an infection or blood in the chest cavity. General anesthesia given. Patient will be asleep and not felt any pain. Two common ways, thoracotomy and video-assisted thoracoscopic surgery. Thoracotomy means open surgery. Risk in surgery, allergic reaction to medicines, breathing problems, bleeding, blood clots, infection, failure of lung to expand, injury to the lungs, pain. Prognosis depends upon types of problems being treated, how much of the lung is removed, overall health before surgery. Indications for surgery. Commonest is bronchial carcinoma, malignancy, primary bronchial carcinoma, isolated secondaries arising from kidney or large intestine, inflammatory, lung resection is required, occasionally for lung abscess, tuberculosis, bronchiectasis. Trauma, stab wounds, gunshot wounds, degenerative, large delay in selected patients where there is compression of normal lung, congenital lobar emphysema. Incisions, lateral incision, posterolateral incision. These follow the vertebral border of scapula and line of rib, 5th, 6th, 7th, 8th to anterior angle of costal margin. Muscles cut are trapezius, LV, serratus anterior, rhomboids, intercostals, erector spine. This incision is used for the lung operation. Here's the picture. Anterolateral incision. These start at middle of the anterior chest up to the posterior axillary fold. Muscles cut are pectoralis major and minor, serratus anterior, intercostals. This incision is used for mitral valvulotomy and pleurectomy. Anterior incisions, first transverse. This passes across the one side of the fold intercostal space to the other. Muscles cut are pectoralis major, intercostals. Second, vertical incisions. Splitting of the sternum down the middle. No muscle cut. This incision is used for open heart surgery. Types of Operation: pneumonectomy, lobectomy, segmental or wedge resection. Complication of surgery: respiratory, infection of the lung, consolidation or collapse, pneumothorax, bronchopleural fistula. Bronchopleural fistula. It implies breakdown of the bronchial stump and it occurs around the 10th postoperative day. If small, it may not be noticed until much later. It is recognized by dyspnea, an irritating cough, and possible expectoration of dark fluid. The patient should be set up or turned on to the operated side to prevent spill over of infected fluid into the remaining lung. You can see the picture of pneumonectomy. Use a normal lung, heart, and there is a fluid. Circulatory, CVT, deep vein thrombosis, cardiac arrhythmia, hemorrhage. Wounds, infection, failure to heal, adherent scar, foot, joint stiffness, SH joint, thoracic spine, costovertebral joints. Fifth, muscle weakness, latissimus dorsi, serratus anterior, leg muscle if unexercised, other divided muscles. Postural deformity, forward or sideward bending, pneumonectomy, removal of entire lung, radical pneumonectomy, along with that of entire lung, mediastinal gland is also removed. Complication: damage to phrenic nerve, damage to recurrent laryngeal nerve. Indication: carcinoma, bronchiectasis, tuberculosis. Incision is posterolateral incision. Preoperative physiotherapy: gain the confidence of patient, clear the lung field, breathing exercise, postural awareness, feet, arm, trunk, leg exercise, splinting of incision during coughing, bad mobility. Post-operative chest physiotherapy: clear the lung field, re-expansion of the lung, prevent circulatory complication, prevent wound complication, regain the arm and trunk movement, maintain the good posture, conditioning exercise. Key points: breathing exercises should be started on the day of surgery if possible. ACBT to remove the secretion and restore the lung volume and capacity. Adequate wound support for huffing and coughing should be taught. Early mobilization progressing to stair climbing on third day post-operativity. Exercise using a bicycle ergometer. Tracheal deviation result into ineffective cuff production. Puffing rather than cuffing is emphasized because of less chances of increase in intrathoracic pressure. If suctioning is required, then take care of stuff. Breathing control with stair climbing may increase exercise tolerance. There's a picture of sprinting. Lobectomy. Indication: bronchiectasis, tuberculosis, lung abscess, carcinoma. Day of operation: half lying, breathing exercise to expand the whole lung, vibration over unoperated site, puffing with splinting, foot or ankle exercise. Day 1, 3 to 4th session. Analgesia to reduce the pain, so patient will cooperate in treatment. Nebulizer therapy or humidification therapy, breathing exercise with inspiratory hold, side lying on unoperated side, chest expansion exercise on remaining side, postural range. Exercise of arm, assisted arm elevation, assisted arm movement in functional pattern, neck exercise. Exercise for leg, foot and ankle exercise, quadriceps contraction, hip and knee bending exercise. Then start ambulation. K2, self-supported splinting, chest expansion exercise, breathing exercise, unoperated side positioning, arm as well as leg exercise, start trunk exercise, discourage the patient for cross-leg sitting. It will occlude popliteal artery and can result into bleed. Day 3 to 4, arm and trunk exercise should continue. Increase the walking distance, stair climbing, group therapy, aerobic exercise. Discharge at 10 to 12 days of post-operative home exercise program, aerobic exercise, hyper chest expansion exercises, ventilatory muscle training. Pain, extrapleural bupivacaine infusion is an increasingly popular method of pain control following a thoracotomy. Bronchial secretions, the appropriate timing and selection of mini tracheotomy can help reduce the incidence of sputum retention. Pneumonia is a serious complication with a high mortality rate. Atrial fibrillation is common with extensive resection in the elderly. Onset is usually 2 to 5 days postoperatively. Wound infection, hemorrhage, significant bleeding, usually involving the bronchial arteries, occurs in 1 to 2% of patients. It is more likely after a pneumonectomy. Segmental resection. A bronchopulmonary segment is removed with its segmental artery and bronchus, used for tuberculosis. Page resection. These non-anatomical resection is used for diagnosis in open lung biopsy and treatment of well-localized peripheral carcinomas in patients with reduced lung infection. Thoraicoplasty. This operation is performed to produce the permanent collapse of a lung. This operation is performed in TB and emphysema. Complications: deformity, paradoxical breathing. Pleural surgery. Pleurectomy is removal of partial layer of pleura. Example, pneumothorax. Visceral layer pleura stick with the chest wall. Pleurodesis, insertion of powder into the pleural cavity, which act as a irritant. Position the patient in 10 minutes for each position. Expansion breathing exercise is performed in each position. Decortication, stripping of the two layers of pleura that have become adherent with each other. Example, emphysema. Pulmonary rehabilitation. Pulmonary rehab (PR) is a comprehensive intervention based on a through patient assessment followed by patient-tailored therapies that include but are not limited to exercise training, education, and behavior change designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence to health-enhancing behaviors. What is pulmonary rehab? Pulmonary rehab programs vary from person to person and from center to center, depending on available resources, but in general it will include multidisciplinary input, exercises, dietary advice, disease education, psychological intervention, behavioral intervention. Contraindication. According to NICE guidelines, the following people should not undergo pulmonary rehab. First, those who are unable to walk. Second, those who have unstable angina. Last, people who have had a recent myocardial infarction. Considerations. Other factors worth considering include unstable cardiac disease, locomotor issues, difficulties following instructions due to cognitive or psychiatric impairments, the attendance of a support person to enable and encourage adherence. Intervention. Physiotherapists play an important role in prescribing, supervising, and measuring outcomes in exercise. Research shows there has been an increase in the use of guideline based exercise prescription methodology using FITT methodology, that is, frequency, intensity, time, and type. Participants engaging in both functional and maximal exercise show statistically significant improvements after pulmonary rehab compared with usual care. Pulmonary care, positioning, exercises, bronchodilator, etc. Functional training, important in end stage disease or extreme weakness or fatigue. Adapt the environment to improve ease. Work areas supported in convenient places to avoid bending. Locate a table to slide heavy objects while working. Chairs at landings of stairs besides bathtubs. Using adaptive equipment and assistive technology. Using good ventilation to kitchens, etc., where fumes are present. Altering performance tasks, slow pace, minimize large body movements. Planned tasks include breaks and rest. Incorporate methods to relieve symptoms. Maintain an uninterrupted breathing pattern, avoiding valsalva. Avoid unnecessary talking during tasks. In obstructive lung disease, the elderly population can pass during lifting tasks. Lean forward, increases the intra-abdominal pressure and pushes the diaphragm up in a more advantageous position and allows the accessory muscles of inspiration to pull the chest into inspiration. In restrictive lung disease, rapid shallow breaths are easier. This prevents elastic resistance of the respiratory system. Relaxation of non-respiratory muscles using biofeedback reduces anxiety related to dyspnea. Specific exercise intervention. Exercise prescription should include supervised aerobic exercise and progressive resistance exercise. Exercise should be individually prescribed according to the initial assessment and goals should be identified and agreed. For mild lung disease, have symptoms with extreme effort, cough, sputum, pyrometry show the predicted vital capacity, ABG normal mild hypoxemia, exercise testing and training, individual exercises, prescribed, formal rehab not required. For moderate lung disease, subjects with moderate lung disease typically have shortness of breath on daily activities, Episode of acute pneumonia after major surgery is when the pulmonary disease is identified. Demonstrates good results with pulmonary rehab. Vital capacity FEV 155 to 70% indicates shortness of breath. Exercise testing start at a low metabolic equivalent MET, that is 1.5 MET, and progress 0.5 MET at each stage. Monitoring ECG, blood pressure, heart rate, or perform a 12-minute walk test. Exercise prescription, intensity, heart rate at a point when patient is 2 to 3 dyspneic on the box scale of perceived exertion. Frequency 5 to 7 times a week. If symptoms develop, use oxygen. 4. Severe lung disease. Shortness of breath on most activities of daily living. Vital capacity and FEV1 less than 50%. Needs oxygen at rest. Some show are ventricular dysfunction. Testing, low-level intermittent test or exercises set at a steady endurance test of 2 to 3 METs. Training, interval training, short exercise walks, frequent rest. Once a day when duration increases to 20 minutes, 5 times a week. Intensive monitoring, when monitoring oxygen every decreases in SpO2 of 3% should be noted. If the drop reached less than 88%, SpO2 oxygen therapy is indicated. Thank you.